Okay, so welcome to our final week of these COVID conversations with PHE Health and Justice. I've got Linda Stent and Rachel Campbell with me today, and what we're hoping to talk about is issues around workforce. So in the last few weeks, we've been looking at the various ways in which Public Health England have been working on COVID-19 in prisons. We had an introduction about different approaches that we're taking around population management. We've talked about outbreak control team meetings and surveillance. And so now this last session is on workforce. So Linda, maybe I could come to you to introduce yourself to everyone.
Yeah, hello there. So my name's Linda Stent. I'm a Health and Justice Lead working for the Public Health England South East Centre. So I cover all of the health and justice settings across the south east of England, particularly Thames Valley, Hampshire, Isle of Wight areas. And I've been with Public Health England since 2013. And then previously, prior to that, I've got experience of working within the custodial environment. So I was a senior officer on a first night induction and detox unit in the female prison estate, which has provided me with a wealth of knowledge around prisons and how they operate.
Brilliant, thank you. And Rachel, do you want to introduce yourself?
Oh, sorry. Yeah, hello, my name's Rachel Campbell. I'm the Health and Justice Lead for the South West PHE. I started working in the Health Protection Agency back in 2006, and we transitioned to PHE thereafter. And I took up this post in 2013 around health and justice. So I'm a nurse with over 30 years experience, and when I was in health protection and prior to that, there's always been an interest in the wider determinants of health and the sort of issues that we have for many of our population. And this just gave me the opportunity to look at that in more detail. And prior to that, in the Health Protection Agency, I was one of the health protection, health and justice leads for the South West.
Brilliant, thank you. And you're both currently working with the national PHE Health and Justice team. Because of wide range of experience and knowledge of kind of what's happening locally, but you've also been supporting our national response as well. So you've got a real insight at what's happening at local level, but also at national level. So I'm really pleased that you've been able to give us a bit of your time today for this conversation as well. And we've talked in the past about how discussions have gone in OCTs, and Linda, we were talking about the transmission dynamics, how COVID-19 is coming into prisons, and you were telling me about that dynamic around staff and prisoners, and you had quite a good example, and I wondered whether you could tell us a little bit about that. Linda, are you there?
Linda, you're on mute, I think.
Oh, I think we might have lost Linda for a little while. I think it's frozen. Well, Rachel, in the meantime, are you okay if I come to you? One of the things that we were talking about, so we've lost Linda completely now, so hopefully she can
come back. Yeah.
One of the things that we were talking about was protective equipment, personal protective equipment, PPE, that people are using in prisons, and obviously that's important for both prison staff as well as prison healthcare staff. What's your experience been? What are your reflections as to some of the challenges around using PPE? Linda, we're back. We'll come back to you in a moment. We're just talking about the PPE. No, I mean, it's the realities of working from home and trying to use Skype. But yeah, Rachel, do you want to just tell us how it's been going with PPE in prisons?
Okay, so I mean, PPE forms part of the delivery in any healthcare setting anyway. I think with COVID, there's been a number of things that create challenges. So what we're seeing inside and the need inside a prison and across other secure settings is quite a different message to what we're seeing in the community that's coming out of the media. So it does create some challenges for people. Not that either message are wrong, it's just they're different. So within the secure setting, where we wouldn't normally have non-healthcare staff wearing PPE so frequently, we actually need to implement that for obvious reasons around social distancing. When you have such a large number of people together and you need to deliver healthcare, but also any sort of form of communication and day-to-day living for individuals across the establishments. So when you then see things coming out of the media, what people are choosing to wear or might be the message within the community, it does create some challenges, and it's getting over those effectively and making sure we're wearing PPE at the right time, in the right place, for the right activity. And I think it's also trying to get people to understand that personal protective equipment is important, but it's also making sure that it's put on correctly, that it's changed correctly, so that you keep reducing the risk. And I think those are some of the key points we've needed to get across, so that people don't constantly wear gloves or don't constantly wear masks, but think about what do they need to do and when do they need to do it. So a good example is some of the information that's been produced for secure settings in pictorial form, but also in written form. So it actually gives you an idea of what you need to wear, because when you start to looking at PPE in any great detail, there's a huge range, and it's how far you need to go and what do you need to use. So one of the examples in establishments in the area is that the healthcare team have been looking at the need of their counterparts, and also the prisoners as well, to kind of reinforce to them what do you need to wear, what is a safe system of work, what is safe practice, how do they need to dispose of things, do they need to wear it at what point, and that's been quite useful, because it's also alleviated some of the anxieties for staff who don't normally wear PPE, and it's also helped to advise prisoners for why people are wearing it and when they'll wear it. So it's been generally positive. I think, like everywhere else, the supply that's needed and how they access the supply has probably been one of the biggest challenges. But those things, I think, will peak and trough as we use more equipment than we're used to using. But some of those things are seeming to sort of straighten out and be more straightforward than they were.
Brilliant. Thanks, Rachel. I think that kind of leads quite nicely anyway into, the question that I was going to ask Linda. So thanks for getting back to us, Linda. I hope the connection holds.
Apologies.
It's all right now. But we were going to talk about an example of that transmission, from staff to people in prison. And, that's why obviously PPE is so important. But do you want to tell us a little bit about the example?
Yeah, thank you for that. So I think we've had varying degrees of transmission across all of our establishments, but certainly one of our larger reception prisons in the southeast of England had quite a number of prison staff that were found to be positive for COVID. So there was a real need to identify very quickly some of those risk areas, particularly given that we were expecting it to be very much prisoner related around COVID. And that's not what we saw in this particular reception prison. So they ended up doing some contact tracing themselves within the establishment and absolutely tied it down to a prisoner who was on a bed watch and the staff that had attended that bed watch. And that kind of filtered out to some other establishments, because, as you know, staffing during this time with prison staff off shielding and symptomatic themselves has had an impact. So staff from other establishments are sometimes used on bed watch, which I know infiltrated into Rachel's patch. So very quickly what we did was our prison group directors had to put out some narrative around restricting staff to only do bed watches in their own home establishments to reduce that risk and the spread thereof. So I think it was a really useful example of where health and the prison have worked together very closely to quickly identify where those hot spots have been and to put some guidance out to mitigate that risk. And what that has enabled us to do is to absolutely tie down on 3 separate cohorts between staff and look at some of that tracing to identify potentially where we could see some symptomatic prisoners start to come online. And I think what it's also managed to achieve is to stem the flow of coronavirus through that establishment. So very quickly, people were identified as contacts. We had individuals who were already on our reverse cohorting units, which has worked fantastically well and has stopped any flow throughout the entire establishment. But it very quickly enabled us to identify when we had a new symptomatic prisoner who subsequently went on to test positive. We tied it back to this cohort of prison staff, and by very quickly isolating and testing that individual, we haven't now seen any further cases in that establishment, either in staff or prisoners now for in excess of 6 days. So we're very lucky with the way that that was managed, and that wouldn't have been able to take place without that close working and that communication between prison service, governors and senior managers and the heads of healthcare and the nursing staff, and actually that heightened level of vigilance that's been portrayed between health and prison staff, and they're almost then becoming the eyes and ears across the patch. So they're not health professionals, but they are providing that real useful intelligence for us to be able to stem this flow.
That's really interesting, because that issue around partnership working,
Absolutely.
that we always talk about, how important it is for health staff and prison custody staff to work together. And it was something that I was going to ask both of you about, how do you have some examples of how that's worked on the ground in reality? So we've got this national partnership agreement where we've got agencies at the highest level agreeing to work together, and health protection is part of that. But actually on the ground, have you got some examples of how people are working together?
Yeah, so if it's okay for me to go first.
Yeah.
Where we've not seen the real level of outbreak in our establishments, we've still been keen to minimise any impact and risk around that. We don't want to see the big peak that everybody was expecting. So what we have done is done some very focused incident management team meetings. So they include ground level health and senior managers, but they also include strategic partners from HM Prison Service, Public Health England and NHS England. And we've also included community directors of public health within that as well, because one of the things we're finding is that if we have a focused meeting on either a particular issue or an area of concern that we need to allay people's fears around, the idea is to get those people together very quickly so that we can discuss arrangements. So particularly some of our establishments have found it difficult, given the Victorian nature of some of our prison establishments, have found it very difficult to initiate reverse cohorting units. So we've had a lot of discussions around how we can minimise impacts on the regime of the establishment and still allowing that churn to come through where we know that courts are coming online, but also to enable the safety of the prisoners within our care. So we've maximised those discussions. I think it's gone a huge way to improving that real joint close working and communication with partner organisations. And by including the community, it's really key for us that we remember that the prisoners aren't in prison forever, and that actually there is this transition to the community that we do need to prepare for, and we do need to include partner organisations in order for us to do that effectively. So they've been a real use to pinpoint down areas of concern.
Thanks, Linda.
Yes.
Rachel, what about you?
So, just picking up on what Linda's saying, I think, that general whole system, whole prison approach, and very key in that is the communication. So in the Southwest, we've taken a slightly different approach. And one of the reasons for that approach was to make sure we had the capacity to respond, because like Linda, we were expecting much more sort of explosive situations. And to date, we still have a long way to go, but to date we haven't seen the trajectory of cases that we expected to. But I think, heightened vigilance, awareness and implementing those practices that we have are absolutely crucial. So we started to look at cluster outbreak control meetings. So we've got quite nicely and quite conveniently 2 different providers for our clusters. So it enabled us to split them in 2 and have weekly outbreak control meetings, not dissimilar to what Linda's describing. So again, it's that ripple in the pond, it's your partners who you immediately work with, the dynamic approach that you need to deliver on all aspects, including COVID and prevention, but also making sure sure that we engage with the community, because as Linda said, people aren't in prison forever. This is, the point of rehabilitation starts as soon as they leave the court and head to custody, and potentially before. So within our OCTs, what we're looking at is early intervention. It gives us as health protection, health and justice and other colleagues eyes on to see what's happening virtually in each of the settings, and engage very closely with healthcare and prison and security, but also our wider partners in NHS England and HMPPS liaison and the local authorities, so that we can explore what's happening. Have we got symptomatic cases? Does that constitute an outbreak? And it also gave us the opportunity to escalate out should we need to, which we have done on occasion. But generally, the communication has been absolutely crucial and has been quite effective today. And some of the reflections from our colleagues has been that they've never sort of had to work more closely than they do now, and yet they're more remote. But the absolute commitment to delivering to support the individuals that they're looking after, but also the safety of all the people that actually contribute to delivering that prison is absolutely crucial. So I think one of the things we also focus on is are there any other key areas as well as COVID? Because what we don't want to do is, Linda will be doing exactly the same, is we don't want to dismiss other things that can contribute to COVID and or health challenges. But at the same time, we need to recognise some of the risks that COVID presents and manage those effectively. But the other thing is about how are you? How are you? How are your staff? What's the morale like? Are there any anxieties? What can we do to support you? How are your prisoners? What are they feeling? Is there something around how missing their relatives, sort of a face-to-face contact, that is creating any challenges? So for the most part, again, this seems to be really well managed. There's nothing like having somebody face to face, and teams have really been, with COVID, pushed into doing things differently that they might not choose to do. But actually the reflection is that positive, effective working relationship, very close communication to achieve the best outcome they possibly can. And we've also had similar reflections from the teams to say that their prisoners have said, we appreciate what you're doing, and it's keeping our relatives safe as well as us. It's not perfect, and it never will be, because we are human beings, but actually the effectiveness has been demonstrated from the behaviours, and the approach to this has been really good. And one of the things they have done in the Southwest is they've implemented a wellbeing manager in each of the settings, but that's available to all staff. So it's not just Rachel and PPS, and it's not just for health or other colleagues, it's for everybody. And there's also then the cascade to the prisoners to make sure that they're okay and what anxieties they might have and any contributing factors. And then there's also working in partnership with the prison council representatives, with the mentors, with the listeners. So there's been a real chain reaction in how that communication has taken place. And I don't think for a minute people want to do that forever, but actually it's been a really good exercise in showing how communication can give effective outcomes.
And just picking up on your point about how staff have been engaging and working with people in prison, the incarcerated people. I just wondered whether you had any examples of how that relationship has been playing out. Has that been a positive experience? I mean, some of the things that you're talking about, Rachel, it sounds like it's been positive, but I just wondered, what your reflections and experience recently have been about that.
I think we've got to keep in mind that everybody, the prisoners and all of the healthcare staff, will have relatives. So I think, the real focus on well-being and how are you is about what's going on for you outside your job, what's going on for you as a prisoner outside the prison, because we need to recognise anxieties that could be there because they are likely to have known or know somebody that's been unwell with COVID, and not being able to see them or talk with them perhaps has probably been more challenging. And I think particularly for the healthcare teams, they are moving from community to prison. So they're moving, from an area where we know there is transmission in the community to an area there isn't. So there's anxieties perhaps about how the transmission might take shape, but also what might be happening for them at home in the community with their relatives. So I think it's more than about the delivery of health within a prison. It's more about the whole person, the whole prison, the whole system, and then that wider community connection and network.
Yeah,
Thanks. Linda,
absolutely.
did you want to come in on any of that?
No, I think it's just really key. I mean, it's such a difficult environment at the moment with the restrictive regime. So everybody, so prison staff and health staff, are finding it increasingly difficult to deliver the norm. They're all used to working in a very different way, and with this, we've been closed to social visits for quite a significant period of time now, and we've got to recognise that plays a significant burden on people, particularly low level kind of mental health issues, that anxiety. They've all got access to social media via television and radio, etc., and they have access to that information, and phoning, as we all know in the community, phoning your loved ones is not the same as having that face-to-face interaction. So I think we've been very lucky that we've got our prisoner reps. And we've got now several of our user voice and service user groups who've set up 0800 numbers, so prisoners are able to dial in and leave feedback, whether that's good or bad. And then we have a strategic, in our patch, once a week, we have a strategic meeting which includes our service user rep agencies feeding back on that. So we're able to work together quite strategically to look into some of those concerns that are raised, which tend to be for all sorts of different reasons, concerns about mental health, concerns about not seeing family and friends, and just general concern about COVID, but also the rhetoric of that is the real heartwarming stuff around the feeling of safety that prisoners have, and the feeling of support and communicated effectively by prison and health staff together, that if they are feeling unwell in any way, shape or form, health are there and are there very quickly. We do have the luxury at the moment that we do have access to testing for prisoners within prison, as well as the staff. So there is that real feeling of joint working and joint and effective communication that's allaying a lot of those fears, and that recognition that that's not just playing out in prisons, that everybody is suffering by that in different forms too. In cell telephony, so we've managed to put in telephones into a lot of our prison cells, which has again improved access for prisoners to contact family and loved ones, whereas when you're on a restricted regime, it's very difficult for people to come out and make telephone calls, and for them to be quality telephone calls rather than a rushed 2 minutes, get off, it's somebody else's turn. But actually some quite innovative use of those in-cell telephones by health. So where they're not able to do that one-on-one clinics or support or conversation to say, how are you? They're obviously able to ring prisoners in their cells, which makes it still quite confidential, especially where we are moving to a situation where we are getting more people into single cell accommodation. So we're able to bring a lot more of these things back online, but in a very different way. And I think it's something that we need to get used to doing for the foreseeable future. And I think we need to start being more innovative around that, the use of telemedicines, etc. So really heartwarming around that. And I guess one of the biggest feedbacks we've got, and not something that I'd want to put out there as a complete positive, but under our early release scheme, we had a number of prisoners who didn't want to be early released and refused to give the appropriate information because they felt safe and secure and well managed by health. So not something you'd want to put out as a thing to do, but I think it's a real testament to the fact that prison and health together are working very closely to allay fears.
Yeah, definitely. And I think you've both, really demonstrated how actually, staff and people in prison are in this together. Their health, their well-being, their lives, depend on each other and keeping each other safe. And, it sounds like
they're a household.
Yeah, exactly.
That's the household. It's just a bigger household to what we're used to in the community.
Yeah.
But that's how they see themselves.
Yeah. And so, that kind of communication, collaboration is just so important to make it work. And I guess, the other workforce really are people like us. So, the public health professionals who are working around this. And, I guess I just wanted to hear a little bit about your reflections about your own roles as working in a national public health agency, because there'll be people out there, watching this, who might be working in a public health agency themselves or working with people in those roles. How's that experience been through all of this?
So if I sort of just start, so it's very different, because when you're used to, people like Linda and I and yourself, integrating face-to-face a lot more with a whole range of people across quite a wide geography, stopping that, we've had to be quite creative in how we do it. And so, using our telephony and using our teleconferencing and video recording has actually been more crucial than ever. And it's learning and developing. I think sort of Linda alluded to it a short while ago. It's how we learn and develop from what we've been almost pushed into doing, not physically by anyone, but by the disease and virus itself, because we have to continue to support, manage and deliver for these individuals in that setting, as well as safeguard, our teams are out there, on the shop floor doing what they normally do and making sure that the outcomes are positive and safe. So it's how we capture some of that information and how we use it for the future, because I think sometimes we've been quite good at thinking, well, actually that's probably not going to work, or there might be a number of issues around it, and this way we've had limited choice. And I think that limited choice, although it's not been a comfortable experience at times, because any change and anything different isn't, but what it has enabled us to do is test things out, test things that we might have thought, well, actually we'll try that at a later date because it might be a bit too challenging at the moment. We've been able to do that, and it's given us some real development ideas and some real learning opportunities. And I think it's also really helped us to establish community and place, because these establishments are community. Those individuals that live there, work there, visit, voluntary sector organisations, professional visitors, it is part of a community and a wider community that it sits within. And that sort of place-based consideration is really important as well, and how we use that as a positive. I think the communication for me has been absolutely crucial, because you are, as a public health professional, quite isolated, because although you've got access to your teams and we've got a lot of virtual information and things are quite easy, and I suppose for people like Linda and I, we've had contact with yourself and with other colleagues in the national team and also our centres, but it's so different to what we would normally do. We've had to be quite creative. But I think possibly, whereas, Linda and I will probably speak to each other quite frequently over the month, I think we've spoken to each other much more, because you want to bounce ideas, you want to discuss opportunities, there are some real challenges, and learning from each other's experiences, what's worked, what has been less effective, what we could do more of, and using those to direct how we deliver as public health professionals has been really positive. I think the well-being thing for me has been crucial, and I've been doing some other study in the mix with this, and I know I've neglected my own well-being, because you do your job, you get on, and then you go to bed, and then you get up and do it again. So I've actually started to do much more exercise of an evening and change my plan, and actually have been far more effective in what I'm doing that way. So it's quite good at getting you to think about what do you do for yourself. So quite a lot of positives, quite a lot of challenges, and I think it's helping us look at things in a different way and actually think about what next, and so what, because I think none of us are under any illusion that this is just suddenly going to change or disappear. It's going to be a gradual transition, and I think what we've got to think about is how do we restore what we need to deliver gradually, effectively, and what do we do should there be any further challenges that are presented to us with this disease as we look to manage it, prevent it, but also look at how we might do further testing it and or if vaccines and treatments become available at a later date. So I think there's a lot of us to for us to think about
Yeah.
that there's a lot of opportunity that's presented to us about how we can make sure those individuals that we're looking after and how we support the staff in doing that and doing it in a slightly different way.
Mm. Thank you. And Linda, did you want to say anything about kind of your reflections, how it's been for you as a public health professional?
Yeah, I guess, mirroring so much of what Rachel has said, this has been a complete change of life and working life as well as personal life for everybody. And it's not a 9 to 5 anymore. So, this is my bedroom is my office currently. So it is ultimately fall out of bed and start work, which is great for the commute and avoiding public transport. However, you're constantly trying to be the next step forward, and you're trying to preempt all of this stuff that's going on. It's about, although we work within health and justice, it's looking at that wider whole system approach. So like I mentioned earlier on, some of the things that we do in a prison to ensure that we are meeting the health needs of that population is by relying on community services being able to deliver those into the prisons. And that's something that we're having to struggle with at the moment because they're just not available. So we're trying to have to think outside the box. I think for me,
Oh, Linda, I think you're breaking up. I don't think the connection's been great. We're demonstrating, but
She's back.
You're back. We missed a bit of what you were saying.
It was
but
the important bit. It's the feeling of value.
Yeah.
It's not just about prisons. It's this whole situation. Everybody is.
Well, I think they're gremlins in the system today, aren't they?
There are.
But I think Linda's right when she's saying about the value. It's our value as professionals, valuing the people that support us, and then valuing the people that are delivering. And I think, like Linda said, this is a whole new way of working, and certainly not to isolate ourselves to any extent, but actually doing this in a very measured way, that the outcomes are positive.
Yeah.
And things that we've not said no to, but haven't said yes to. Actually, there's some things that how do we keep those yeses?
Yeah.
And how do we use it?
Yeah. Okay, well, I'll draw our conversation to a close, but thank you so much for your time. I know you guys are incredibly busy trying to support local systems and to support us as a national team to deliver our response as well. So thanks very much for today, and I'll let you get on. Thank you.
Thank you very much, Sunita. Thank you.
Thanks,
Bye-bye.
Sunita.